This session today is aptly called Registry Evidence versus RCTs. Which ones should we believe? And in fact, using clinical examples, we will show the pros and cons of registry evidence and RCT evidence and contrast and compare these two data sources. The session will cover how we can generate causal assumptions from observational evidence, and we'll describe in many ways many of the traps that we fall into when interpreting evidence from both sources. Specifically, we will talk about contrasting evidence for bipolar versus unipolar hemiarthroplasty for hip fractures, and we'll provide broader examples of where evidence from these two sources has differed in the past. So here's the point. I mean, there are lots of debates around which approaches are better, and I think the example of hip fractures couldn't be a better one. Let me introduce a friend, colleague, and someone I've respected and followed for many, many years, Professor Ian Harris. I suspect known to many of you already, but currently an individual who I think leads in this particular area of thought. Welcome, Ian.
Thanks very much, Mo, and hi, everybody. So just a bit of background. This is a topic that has been of interest to me because I have a sort of epidemiology background as well as orthopedic surgery, and I conduct RCTs and I'm a big supporter of RCT evidence, but I also am on several registries, and it surprises me the strength of the argument that some people believe that registries are the only answer and that RCTs are all wrong. And some people believe that, RCTs are the only answer and that registry evidence is a waste of time. And you get these sort of, bipartisan views of things. And the reality, of course, is neither. And so this is what we're going to be covering today. And I'm going to introduce my two co-presenters. First, there is Sam Addy. Now, Sam is an orthopedic surgeon from Sydney. All of us are from Sydney in Australia, but also epidemiologist, a PhD in particular, looking at the quality of evidence, of RCT evidence in surgery and systematic review evidence. And with him as well is John Ferry. John is an orthopedic trainee here in Sydney, but he has just begun doing a PhD under the supervision of Sam and I. And one of his first papers is really sort of right up this alley. And a lot of his PhD is around sort of comparing RCT to registry evidence. So to give you an overview, Sam's going to give us an overview of this sort of observational versus experimental argument with a couple of examples. John is going to present his specific research in hip fractures and compare the RCT evidence to the registry evidence and show how they give us different things and they both have some value. And then I'm going to round it out with an overview and hopefully some solutions to solving these problems. So we'll kick it off. Mo, at this stage, we'll get Sam to give his presentation.
Thanks, Ian, and thanks, Mo, for inviting us to present this evening in Sydney, but morning your time. So before John and Ian do a deep dive into the issues related to registry and RCT evidence, we thought we just wanted to just give a brief recap about the broader issues about observational versus randomized evidence. And what better place to start than the evidence-based medicine pyramid? And I'm sure many of the listeners would be aware of the EBM pyramid, which basically stacks the studies in terms of how rigorous their study design is. And all what we're aiming for really is that achievement of scientific truth, which is represented here by the peak of that EBM pyramid. So next slide, please. So if you consider all of those study designs, what they're essentially doing is recruiting a study population, and there's methods involved with all of the steps in that study design. And the more rigorous studies will perform those methods more stringently and reduce the bias that might result if they're not performed properly. And any of these steps can be subject to bias and error. So the selection of the study population, the measurement of the exposures and the comparisons, and of course, measuring the outcomes. So each of these stages can be subjected to different forms of bias. Now, we can try to address each of these by the study design or perhaps statistically. Next slide, please. But the one issue that really keeps coming back in observational designs is the issue of confounding bias. When I'm trying to examine if there's a causal relationship between, in this example, a specific type of knee replacement prosthesis and revision surgery, I might observe that association in a study, but if I ignore the confounding effects of, for example, surgeon volume, I might miss the fact that there's an association between surgeon volume and a specific type of knee replacement. So surgeons with higher volume, for example, might be using a specific type of knee replacement. And we know that both of those things can be causally related to revision surgery. So that's just one specific example of confounding. The issue with confounding is that they can be known, but even of more concern, it can be unknown. And this is the problem. So known confounders can be dealt with by study design, for example, or by statistical approaches. But there's a whole range of unknown confounders that I just may not even be aware of that also may confound that observed effect. So next slide, please. So the only real weapon we have against confounding is randomization. And you may be aware in randomization, we have a study population that is then randomly allocated to intervention and control groups. So just by pure chance, you're going to have a 50-50, hopefully 50-50 allocation of those confounding variables in your two groups. So in effect, what you're going to have at the end when you compare that intervention and control is a pure comparison between only one thing that is different between those two groups, and that's the intervention and the control treatment. So why are we talking about this? This is all very theoretical, right? I mean, bias and confounding, the EBM pyramid. The issue is there is very strong empirical evidence that this actually does matter. So bias and confounding does tend to overestimate the benefits of treatment on average, and also underestimate the harms of treatment. So really observational studies tend to do both of those things when you compare them to randomized trials. And I wanted to just end off by giving a few examples or hard-learned lessons really that the scientific community has really learned from these concepts. So this is an example of a meta-analysis that was done in the field of asthma. So they compared different types of chronic disease management on the quality of life in asthma. So next slide, please. So here you can see how they've pulled the effect sizes from the different study types. Next slide, please. From the different study types. And you can see here clearly that the less rigorous study designs, the quasi-randomized trials, and the controlled before-after studies or the observational designs tend to exaggerate the effects of treatment. So they're more likely to favor the intervention more strongly than the more rigorous study designs in randomized trials. So what about harms? Remember Vioxx, guys? This is the COX-2 inhibitor that was widely used a few years ago for the treatment of arthritis. This is a cumulative meta-analysis published by Uni in the Lancet in the aftermath of the Vioxx disaster. So the smaller, less well-designed, I guess less rigorous trials ignored the harms of Vioxx in terms of cardiovascular side effects. And then in the early 2000s, you'll notice that some of the largest studies
next slide.
picked up on harms. Yeah, next slide, sorry.
Yeah.
Picked up on those harms and actually detected that there were cardiovascular side effects. And then we realized that potentially hundreds or even thousands of people were being harmed by the use of Vioxx. Next slide, please. Another example of underestimating harms is the is the use of hormone replacement therapy in postmenopausal women. So a whole plethora of observational studies in the 80s and 90s actually showed a beneficial effect in terms of cardiovascular events for women who used HRT. But then the massive Women's Health Initiative trial was published, which showed that there in fact was a harmful effect of HRT use for cardiovascular events. So you look at the data here, this is a commentary published in NEJM by Grodstein that showed a 40% reduction in observational studies, but possibly a harmful effect, a 30% harm in the Women's Health Initiative trial. So next slide, please. So there was lots of soul searching as a result of those differences observed. And one glaringly obvious thing that wasn't adjusted for, this is a very good example of confounding, where the observed association or the protective effect was not adjusted for socioeconomic status. And when it was, that observed effect was no longer present. And the other thing that was noticed was the cardiovascular harms occurred early after HRT treatment. So really, in effect, rather than keeping the women healthy women were actually continuing to take the HRT. Next slide, please. So even if we consider RCTs themselves are not immune to bias. And this was a landmark paper published by Schultz and colleagues in JAMA in the mid-90s. So what they did was they compared the outcome effect sizes of the poorly reported, or in effect, the RCTs with poor methodology that did not report adequate methods related to allocation concealment, and then compared those effect sizes to RCTs that had adequate methods of allocation concealment. And on average, they found that those with inadequate methods tended to exaggerate the effects by about 40%. So really, these observational versus randomized evidence arguments are not just theoretical. They do have a very strong empirical basis, and the scientific community has learned some very hard lessons, which is why there's a bit of apprehension when you're talking about observational versus randomized evidence. So I'll just hand over to John now, who's going to talk a little bit more practical, a few more practical examples about registry data.
Thanks, Sam, and thank you to Mo and the Ortho Evidence team for inviting us to talk, and thanks for Prof for the invitation. I will talk briefly about part of my PhD research. It was a registry-based study looking at all the unipolar and bipolar procedures that have been recorded in the Australian Joint Registry since 1999. Next slide, please. So classically, displaced subcapital neck ischemic fractures have been managed with hemiarthroplasty, and contemporary surgeons have offered two choices of prosthesis, either the unipolar prosthesis or the bipolar prosthesis, which features that additional articulating surface between the femoral head replacement and the stem. Next slide, thanks. And the reason that additional articulating surface was introduced was to prevent this complication, which you see here on the left, which is a historical X-ray, which shows that the prosthesis has started to migrate into the pelvis. It's called acetabular erosion. Next slide, thanks. So what do the randomized trials tell us, and which ones should I believe? Hit next. So if you look at the trials and break down what sorts of prostheses they compare, you need to get rid of half of them straight away, because they compare monoblock prostheses. And then hit next. You're left with 5 trials that include modern prostheses, cemented designs of varying lengths of follow-up, the majority 12 months or less, and the longest series 48 months. Next, thanks. But when you look at all the meta-analyses, and this is probably the highest quality one, they show us that there's really no difference in terms of hip function, acetabular erosion, or revision surgery, but you're not quite confident on how good those estimates are when they combine a whole different series of operations and prostheses. Next, thanks. So what have registries already told us about hemiarthroplasties? Next, thanks. So they show that there is probably a difference in revision for acetabular erosion. We know that from the Swedish registry, but they don't detect a difference in overall revision rates. It's well established now that periprosthetic fractures, a major risk factor is using an uncemented stem. And it was identified earlier on in some of the Nordic registries that a posterior approach led to a higher incidence of instability. Next. So internationally, you observe a large amount of practice variation in terms of countries preferring to use one prosthesis over another or a mixture of prostheses. Next. So we sought to compare the risk of revision for modern unipolar and bipolar hemis for fractured neck of femur using methods known to adjust for known and unknown confounders using Australian registry data. And our hypothesis was that we believed the theory, and we thought that the unipolar hemiarthroplasty would probably have a higher long-term risk of revision based on the increased shear forces on the acetabulum. Next, thanks. So this is how we broke it down. We got to use Kaplan-Meier survival analysis to get the cumulative percent revision for both prostheses. We use Cox proportional hazards and multivariable regression analyses to adjust for the known confounders. Those are the sorts of demographic details that are collected as part of the registry paperwork. And then finally, we used a novel method, the instrumental variable analysis, to adjust for the unknown confounders. And typically, the classic unknown confounder in the NOF population is frailty. We don't know what the surgeon's seeing at the end of the bed and whether that's influencing what prosthesis they choose to use. Next. So there's just over 60,000, close to 63,000 procedures now logged in the Australian registry, which is roughly about 100 times the number of procedures from randomised trials comparing modern prostheses. And there's a fairly typical NOF population, mainly female, mainly in the early 80s, and of varying levels of comorbidities. Next, thanks. And hit next again. The reasons for revision, or the proportion of the reasons for revision, was similar for everything except acetabular erosion and fracture. We noticed that there was a greater percentage of revisions for unipolars, for acetabular erosion, but then unusually we noticed, or unexpectedly rather, that there was a higher proportion of bipolar procedures that were revised for fracture. Next. And so this is what the cumulative percent revision looks like when you track it over time. And just bear in mind that the length of most randomized trials is about 12 to 24 months, which is about 10% of this entire time frame that we're looking at. And it does look like over time, there is a higher risk of revision with a unipolar hemiarthroplasty. Next, thanks. And the reason that it perhaps there is a higher risk of revision is that it may be being driven by revision for acetabular erosion. And in fact, over time, the strength of that association increases. That's time from initial procedure. Next, thanks. And then when we dug down again, similarly, there's a higher risk of revision for periprosthetic fracture for patients that receive a bipolar prosthesis. That's independent of stem fixation and stem type. In a separate analysis we conducted. Next, thanks. And so these are the headline figures. So just hit next. Initially, at first blush, it looks like that the unipolar hemi has a lower risk of revision in the first 2.5 years after surgery. But once you adjust for the known confounders, that relationship is no longer significant. It doesn't matter which prosthesis you're using in the first 2.5 years, there's no difference in revision rate. But after 2.5 years, there is it favours bipolar prostheses. Once we adjusted for the unknown confounders, that's the third column on the right, the strength of that association gets even stronger, giving us confidence in the robustness of our analysis. Next slide, thanks. So the main findings were that the unipolar had a high risk of revision after 2.5 years, but before that there was no difference. That acetabular erosion, despite the fact that we've designed a new prosthesis for prevention of acetabular erosion, it's actually a very rare indication for revision. And it's probable that there's no cost benefit to using a bipolar prosthesis if someone has a limited life expectancy on presentation. I did a back of the envelope calculation using Australian government rebate data, and it's about $1,300 more expensive to implant a bipolar prosthesis using Canadian dollars. Our registry analysis allowed to identify that the bipolar prosthesis itself is a risk factor for a periprosthetic fracture. And we suspect that's due to increased activity levels and range of motion with the prosthesis. However, that assertion isn't actually backed up by the randomized trials in terms of what they show. Next, thanks. So the strengths and limitations of when you're using a large cohort observational study, it's comprehensive. It's nearly over 99% of arthroplasty procedures in Australia since '99 have been logged in the joint registry. And that gives us a very comprehensive degree of completeness. It's also linked to the National Death Index. So we get, for the primary outcome of revision, we find out when patients either have a revision surgery or they're deceased. The results were consistent between our two methods when we were adjusting for known and unknown confounders. The duration of follow-up exceeds all the randomized trials, but one of the weaknesses of this study is it doesn't tell you which prosthesis makes the patient's hip feel better. And that's probably where a randomized trial is better suited. Next, thanks. So how do you use this? So when you're presented with a patient in the emergency department, you really need to get a sense of what their life expectancy is probably going to be after surgery. You might use something like the Charlson Comorbidity Index to get a prediction of the likelihood that they're going to be alive in 2.5, 5, 10 years' time. If the patient has a high level of comorbidities, they're not a community ambulator, it's probable that they won't be alive after 2.5 years, and you can be justified using the unipolar prosthesis. But if the patient is expected to live for a number of years, they've got a low number of comorbidities, it's very justifiable to use the bipolar prosthesis. Next slide. Thank you. I'll pass on to Prof.
Right, thanks, John. We'll keep it going. So I'm going to round it out with a talk on how we can take the best of both worlds to make something that's even better. Next slide, please. So I'm going to cover problems with observational data that Sam's already touched on. I'm going to talk about problems with RCTs and give you some rather humorous examples, although you won't be laughing because these are real examples of problems with orthopedic RCTs. And then I'm going to propose one solution to both these problems. Next. So we know that routinely collected data, it's often not collected for the same purpose as research. It's often not complete, it's often not checked. It doesn't go through the same processes as data does for an RCT. And obviously it's subject to confounding. Next. Registry data is often more complete and true. Often it is validated. It's, in the Australian example, it's cross-checked with state level data, but it's still subject to confounding. Next. And to address this confounding problem, you can measure them and you can often adjust for known confounders. But what we can't really adjust for is the unknown confounders when we have observational data. Next, please. There is a whole field of research which is looking at causal inference using observational data. And there are some quite interesting techniques that you can use. One very well-known technique is to match patients. And you can match patients based on fairly broad criteria. There's different kinds of matching that you can do, different statistical methods to do matching. And one that many of you may be aware of is propensity-based score matching, where people are weighted according to their propensity to receive one of the two treatments. And these are some of the methods that we can use to address unknown confounding. Next. Instrumental variable analysis is something that's reasonably well known, certainly in the causal inference field, but not used that much in orthopedics, although it is beginning to be used a lot more in registry science. One of my hats is as one of the deputy directors of the Australian Registry, and we're now refining our methods in this, and John's work has been a big part of this. It's an alternative causal inference method that doesn't rely on having to know all the confounders, the ignorability assumption. So here is it's the instrumental variable is some variable Z that leads to the treatment exposure A, whether that be unipolar, bipolar, whatever, and then which leads to X. And the idea that Z leads to X without going through the confounder. An illustration is always best. I'll go to the next slide. I've used John's example and I've kind of reworded it a little bit. So rather than comparing all bipolar cases to all unipolar cases, because we don't know why they were chosen, we can use hospital or surgeon preference. So you'll find that some surgeons will normally use a unipolar. Well, they might sometimes use a bipolar. Other surgeons will normally use a bipolar, unless there's some sort of extreme example as to why they wouldn't. And you can use that variable through some statistical methods to work out its influence on the outcome. We've done this before with use of patella during knee replacement, where it's difficult because some surgeons will be more likely to replace the patella if the patella is worn, and less likely to replace it if it's not. So you're not comparing the same people. You're comparing different patients when you do a straight patella replacement versus no patella replacement assessment, and you're getting obvious confounding. So what we did there is we took surgeon preference as a variable, because some surgeons replaced 90 to 100% of patellas and some surgeons replaced 0 to 10%. And so you can see it's kind of like an intention to treat analysis. If you get treated by a surgeon who normally does a bipolar compared to treated by a surgeon who normally does a unipolar, what's the difference? So that's the way I look at it. It's kind of like an intention to treat analysis using observational data. Next slide, please. But the reality now, this is an area I work in every day, and I can tell you that 90% of the time that we spend doing reports on registry data is trying to deal with confounding. It's an enormous problem. So that's observational data. Next slide. Now let's talk about RCTs for a little while. This is a review that Sam did. Click next, please. He looked at the reviews of trials, found sample size calculation in less than half, random sequence generation in less than half, allocation concealment in less than half. And interestingly, one of the factors that was associated with high quality was where an author had some kind of statistical or epidemiological training, which was interesting. Next slide, please. And these are some more papers out of Sam's PhD, looking at the quality of conduct of meta-analyses. Next slide. And what he did is he looked at how good the quality was of randomized trials and systematic reviews in surgery, but in trying to score meta-analyses, for instance, most of the trials didn't even have half the data that was required to fill out the quality scores. Such was the low quality of a lot of these things. And so let's look at a few examples. If you go to the next slide, this is just plucked out of 2011, and this is a randomized controlled trial. It's platelet-rich plasma compared to no platelet-rich plasma in rotator cuff repair. So, that's a good study, yeah. Let's look at the results. And so we go to the conclusion of the abstract. Now, keep in mind that most people only read the abstract, and this is lifted word for word out of the conclusion of the abstract written by the authors about this RCT. So the conclusion is it's possible that platelet-rich plasma may be beneficial for large and massive rotator cuff tears. Okay, that's good news. Also, given the mix of platelet-rich plasma preparation products available on the market, it's quite possible that other preparations may be even more effective. So the conclusion is that this technique may be beneficial for large and massive tears, And if we tried some other things, it might even be better. So that's a pretty positive conclusion. Now, when you look at this randomized controlled trial, this was a randomized controlled trial of platelet-rich plasma in patients with small and medium tears. Large and massive tears were excluded from this study. They only looked at small and medium tears. They found no advantage to platelet-rich plasma. So the study showed no benefit to platelet-rich plasma in small and medium tears. The conclusion was that it may be beneficial for large and massive tears. This is such a biased reporting of what could have been a very good study that it just makes you think when you read a lot of these articles that maybe if I'm reading the abstract, I'm not getting the full picture. Let's go to the next one. I think I've just got two or three examples here. This one I love, many of you may know. This is a systematic review. Now, there's been a lot of systematic reviews looking at meniscus tears. We all know that. They pop up all the time. And this systematic review, surprisingly, found no difference, the same as all the other systematic reviews. So all systematic reviews of meniscus tears have shown no difference was found between arthroscopic meniscal debridement compared with non-operative management. The conclusion was that more research is urgently needed to support meniscal surgery because we know that it works. And so they made the argument that we need to keep doing randomized trials until we find one that shows it beneficial, because the evidence so far has been so negative. Again, a very sort of twisted conclusion. And the next one, and this one's really highlighting a problem. This is looking at randomized trials published in Chinese journals. So these are not necessarily Chinese articles published in, say, American journals or other English-speaking journals or German journals. These are published in Chinese journals. And how many of them are actually randomized? So they pulled randomized trials. So these are trials that said they were randomized, or they had the word randomized in the title. And they looked at the methods and found that less than 7% of them were actually randomized. This can be shown with the next slide, which is a fairly recent, I might be missing a slide. Say there, look, this is just to show you the bias in low quality trials. So each dot there is a study looking at defective magnesium in post-myocardial infarction. And when you look at all the little studies, they show that magnesium is really effective. And it wasn't until a study with nearly 10,000 patients in it, which was a very high quality study, showed absolutely no difference at all, did it stop being used. But look what happens when you do a meta-analysis of the one good study and all the low quality studies. You get a biased result. So this is another problem with producing bad randomized trials. They shift the evidence towards effectiveness, which is what Sam was pointing out as well. Next slide, please. Hopefully I haven't skipped a... okay. Yeah, so this is fine. So what are the problems with RCTs? I've pointed out that they're often low quality, but they're also hard to do. They cost a lot of money. Next. They're often small, and John showed this very well with some studies with 50 or 60 patients. Next one. And often they're not generalizable, particularly if they're very restrictive in their inclusion criteria. Next slide, please. So how do we improve the quality of any study? We reduce the bias and we try and improve the generalizability. Next slide. So it's the internal, next, and the external validity that we can try and improve. Next slide. External validity, so the applicability or the generalizability of randomized trials is often criticized, but if we do more real-world trials, so-called pragmatic trials, trials that reflect usual practice and incorporate these trials within routine practice, they're much more generalizable. Next. So these are the problems with RCTs. How do we address these problems? So click next. Generalizability, we can do more pragmatic trials. Time and cost, we can do efficient trial designs. Small studies, we can make studies larger, do multi-center studies. The short-term follow-up problem is we can do them longer, but it's going to make the study more expensive. And trials are just very hard to do. How do we address that? Well, we make it easier because we make people more used to doing it. We build up the infrastructure around trials. We improve the scientific literacy of people in the orthopedic community. But a lot of these things can be addressed by one thing alone. If you click next, just by, and keep going to the bottom, if you put trials into routine practice, you kind of address all of these things. And this is where I'm getting at. What I'm going to show you is a trial design which really takes the best parts out of an RCT and the best parts out of registry science and puts them together to make an even better product. Next, please. So this is the registry nested trials, which many of you have heard about. So we can leverage, somebody's got their mic off. We can leverage these data and systems in place at low cost, at very large scale, and do these multi-center pragmatic trials. So I'm going to take you through a couple of those and then we'll wrap up. So the next one is, this is the skeleton on which we have built our clinical trials platform. The Australian Registry now, which covers all joint replacement in Australia, now does a routine pre- and post-operative patient-reported outcomes data collection. And we've built an electronic data capture platform called RAPID, which stands for Real-Time Automated Patient something data capture platform to allow these sort of nested trials. Next slide, please. And Crystal is the first one, and we used the funding we got from Crystal to build this platform. So this is looking at VT prophylaxis. Now in Australia, surgeons are pretty much evenly divided between using aspirin alone, and I know that in other countries many people use something else and then aspirin, but in Australia we use aspirin from day one, or low molecular weight heparin from day one. And the country's pretty divided, and there's this perennial argument, and it's never been solved because there's never, the largest RCT to date had about 780 patients in it, which wasn't large enough, and it was stopped early. So we're doing a cluster randomized crossover trial where hospitals are randomized to use one or the other, and then they cross over to use the other. And the advantage of that is each hospital sort of acts as its own control. It means that everything's very well balanced when it comes to socioeconomic status and surgeon and these other variables and hospital protocols about mobilization. Everything gets balanced out when you have the crossover component of a cluster randomized trial. We're recruiting from 32 sites. We will recruit 15,000 patients in about 2 years. We've recruited a little over 8,000 so far in a little under a year, but we have been greatly slowed down by the virus. But hopefully we'll pick up again. But that's the kind of study you can do on such a large scale using virtually sort of automated patient data collection by nesting it within the registry. Next slide. And these registry nested trials are pragmatic because not only do they reflect everyday practice, they are everyday practice. They're completely embedded in everyday practice. These are all patients in these hospitals that are getting a joint replacement, a part of the study. So it's very efficient. You know, to do a randomized trial of 15,000 patients would normally cost an enormous amount of money to set up and then dismantle again. You can do large multi-center trials, and you can do long-term follow-up if you need to. We probably don't need to for this particular study. So just click next a few times. And you'll see that this now addresses, these registry nested trials address all of the problems of randomized trials being not generalizable, too hard, too costly, not going for a long time, not powered for rare events, for being too small, and it's got the big advantage of randomized trials in that it's got randomization. So it's really the best of both worlds. Next slide. This is the next one we're working on, and this is again part of John's PhD. So we're looking at dual mobility versus standard total hip for hip fractures. It's another large-scale cluster randomized crossover trial, but in this one, we're not even using the clinical trials platform because we don't need individual patient consent because both devices are being used as part of standard care, and all of the outcomes are being measured by routinely collected data. So this is hospital data and registry data about dislocations, death, reoperations, revisions. We've got all that data. So follow-up is already there. Next one. And that's fine. And the next one, just on a smaller scale, we're doing a study, a 2x2 factorial study, looking at computer navigation versus robotic and kinematic versus mechanical alignment in knee replacement. Now, we only need 300 for this, but we can recruit these patients in 6 months. Now, we don't have to embed this study in the registry, but we can because they've got the platform ready to go. They've got the personnel. We're doing this study for about what would be about $100,000 US, which is really nothing in the world of high quality RCTs. And by nesting it in the registry, we get long-term outcomes on the revision rates of the knee replacements that go in. Next. Next. I'll wrap up. So there's other ongoing benefits in that this provides infrastructure to make trials easier to do in the future. We get surgeons on board and they get their expertise up in RCTs. Trial activity gets expanded in all hospitals that are involved, and it enhances the uptake of the findings. If the surgeons all over Australia are the ones that were recruiting patients for the study, they're going to be more likely to believe the results. Next. I think, we've got plans for the future, but I think just go to the next slide, the final slide, because we're running a bit over. So nesting trials within routine data collection really takes the best of both worlds. You've got this already set up data collection system, which is multi-center long-term data, and we throw randomization into the mix. We get better quality, efficient studies that reflect real-world practice. And just click next and next. So we address the problem of internal validity and external validity of trials. Thanks very much.